Brilliant. So you can start whenever you're ready.
Okay, right. So good afternoon, everyone. My name is Eugene Wong. So I'm a ENT surgeon currently working at Kota Kinabalu in Sabah, Malaysia. So I first of all like to thank Anglia Ruskin University Surgical Society for inviting me to give a talk as part of your academic webinar series. So I'll skip the self-introduction today because I've done it last week. So we'll go straight to the presentation. So ENT has always been a specialty that's not very well covered at medical schools. So many junior doctors do find it quite daunting to manage ENT conditions, especially the emergencies during on-calls. So today I'm going to show you how to manage a few common ENT conditions that you are likely going to encounter as a foundation doctor. So here's how I'm going to run the session. So I'll talk about three common ENT scenarios in real life of how we would approach them, but mainly focusing on the practical part instead of the theories. And after that, we'll have a bit of Kahoot session to recap your knowledge and some questions and answers to wrap up the session. So let's get started. So you're the FY1 on call in an emergency department on a Friday night, and you are asked to see a patient with epistaxis. So how do you approach this patient? So before we go and see any patients, you should always make sure that you're wearing the correct PPEs. And this is actually applicable even before the COVID era, because in ENT, so especially with epistaxis, you'll be examining patients' nose and oropharynx. And during this time, it's very highly likely they were going to sneeze or cough some blood on you. So as you can see from this picture, patient can sneeze while having epistaxis, so you might be covered with blood. So make sure that your face and your clothes are protected from blood while dealing with patient with epistaxis. And many of us have made the mistake before where we end up having blood all over us. And the next thing to do is to assess the severity of epistaxis when you first see the patient. So you want to see whether it is just some spots of blood on tissue, or is it a slow ooze, or is it a trickling down, or is it gushing out? So patient, if there's a massive blood that's just gushing out from patient's nose, then patient needs to be resuscitated first because of the massive blood loss. And also because this can potentially be an airway problem where patients start to aspirate on the blood. So let's say for this patient, this is not a torrential bleed and patient is relatively stable, but is still actively bleeding, and you're the first doctor to see the patient. So the first thing to do is what we call a Trotter's maneuver or first aid maneuver. So you ask the patient to lean forward with their head down. So this is so that they don't swallow any blood, and ask them to spit out any blood into a yellow bag or a sick bowl and pinch the soft part of the nose, because that's where the littlest area is and it's the commonest area for nosebleed. So pinch it for 15 to 20 minutes without keep releasing the pressure to check whether it is still bleeding. And during this time, they need to breathe through their mouth. And while patient is doing so, you can then go and get some ice cube or ice pack and put them on the nasal bridge, on the forehead or back of the neck. And quite commonly, we ask the patient to suck the ice in their mouth as well. So all of this will bring the blood away from the nose area. So while waiting to see whether the first aid maneuver works, you can then now start to take a targeted history from patients. So for my talk, I will only highlight the relevant ENT history, but it's good practice for you guys to take a thorough history from patient as well. So you want to find out more about the bleeding itself. So which nostril was the blood coming out from originally? Was it the left or the right? Was the blood coming from the front or the back of the throat? And how much blood was actually lost? So quite often we can quantify them using either spoons, so is it teaspoons, tablespoons, or is it a cupful? And the next thing you want to establish is whether patient has this before. And if they have, you want to know whether how frequent has the patient been having epistaxis and what was done in the past to control the bleeding and how long did it take for the bleeding to stop. And finally, you want to ask about risk factors for bleeding. For example, any history of trauma, such as digital trauma from nose picking, iatrogenic, for example, they recently had a nose surgeries, and any bleeding disorders, any recent URTI, any history of high blood pressure, and also the drug history is quite important. For example, are they taking any aspirin or warfarin? So let's say after 20 minutes, the patient's bleeding slows down but continue to still ooze some blood. So normally this is when the emergency department doctor will then refer the patient to ENT for further management. And at the same time, they should have taken some baseline blood for full blood count, clotting screen. And if you suspect patient to have been losing a lot of blood, you want to send some blood for group and safe or cross match, and also insert an IV cannula in case patient needs IV fluids or blood transfusion. So let's say now you are the FY1 on call for ENT and you get this call from ED. So what can you do? So same as before, you want to make sure that you are fully protected with your glove, face mask, shield, apron, because you don't want to get your face or cloth covered with blood. And then you need to make sure that you bring the correct equipment to the emergency department. So in real life, in most of the hospitals, we will have a box full of ENT equipment that's either kept in the ward or in ENT clinic that you can then bring to emergency department. So some emergency department have their own box of ENT equipment as well. So the initial aim is to examine the patient and try to identify the bleeding point. So what equipment do you need? So you need a headlight to be able to free both your hands for procedures. You need something to open up the nostril so that you can see where the bleeding is coming from. So you can either use a tadicum or a Killian speculum. And you need suction to remove any bloods or clots from inside the nostril, again, to allow you to see the bleeding source. And finally, you also need a tongue depressor, which is not in this picture, to look in the oropharynx to see if there's any blood that's coming out or trickling at the back of the throat. And also, we use this quite a lot. So this is the cofenalcan. It's got local anesthetic and vasoconstrictor in it. So we would usually soak a cotton ball in this and put in the nostril to slow down the bleed. So let's say after putting the cotton ball with vasoconstrictor in the nostril, you manage to identify one bleeding point in the little area. So what you can do is you can cauterize the area either with silver nitrate, which is a chemical cauterization, or if in the emergency department you have bipolar machine, you can also bipolar it using diathermy. And this is how it looks like after silver nitrate cauterization. So you have this whitish discoloration. And if the bleeding has stopped, you can then apply some ointment around this area, either Neseptin or chloramphenicol. But if you can't identify the bleeding point, so it's basically either bleeding too much or there's too many bleeding points, that you can't really cauterize, or you have already tried cauterization but it continue to bleed, the next option is usually anterior nasal packing. So the aim is to compress the bleeding vessel. So you can either use a rapid rhino, which is essentially a balloon pack that can be inflated or deflated according to how much pressure you want to exert, or marocell, which is a dehydrated sponge that will expand when it's in contact with blood or fluid, and therefore will compress on the bleeding vessel as well. And if the bleeding is from the back, so it's a posterior bleed, then you can perform a posterior packing instead. So you can use an anterior posterior rapid rhino, which is essentially a rapid rhino but it's longer so that it can reach the posterior part as well. Or you can use Foley's catheter and ribbon gauze. So what happens is you can insert a Foley's catheter or a urinary catheter from the nostril until you can see the tip of it from the mouth. You inflate the balloon and pull it forward again until the balloon is lodged at the nasopharynx so that it's now closed off the area. So any bleeding that happens, it can't trickle down backwards. So while maintaining this pressure anteriorly, so you're pulling this Foley's catheter anteriorly, you start to layer the inside of the nose with ribbon gauze. Usually soaked with BIP, which is the bismuth iodoform paraffin paste, the yellow material. So you layer it until the whole place is packed, and then you secure the Foley's catheter anteriorly with an umbilical cord clamp. The important part is to make sure there's no contact or pressure necrosis on the alar. So you need to make sure this area is well padded. So usually, this is the limit for junior doctors once you've done your posterior packing. If it continues to bleed, there are many other things that we can do. We can bring patient to OT and do sphenopalatine artery ligation. We can also send patient to intervention radiologist for embolization of the bleeding vessel. If everything fails, we can do an ECA ligation, the external carotid artery ligation through the neck as well. And once we have managed to stop the bleeding, it is important to correct any identified underlying cause for the bleeding that I've mentioned in a few slides back. For example, to withhold warfarin, treat the hypertension, or correct any clotting disorders. So this is for the first patient. If you have any question, you can put it in the chat box, or you can email or message me later on as well. So hold on. So let's move on to the second patient. So you are now the junior doctor doing your GP rotation, and a patient came to your practice with 1 week history of sore throat. So how do you approach this patient? So this is slightly different from the previous scenario because there's no urgent resuscitation that may be required to be done straight away. So you can start by taking a history first. So the key things to focus on your history are the presenting complaint and any associated symptoms. So for sore throat, which is the presenting complaint, you want to know about the onset, duration, any exacerbating factors, relieving factors, and include all the treatment that has been received for the current episode. And in terms of associated symptoms with throat, you want to know about dysphagia or dinophagia, voice change, any difficulty breathing, and if there's any notable lymph nodes in the neck and any systemic illness like fever. And the next important thing in the history is about previous episodes, because for us, we're probably suspecting something like tonsillitis. So you want to know how frequent has the patient had it in the past and its impact on the quality of life. For example, has the patient been needing to be off school a lot, off work a lot, and have they been admitted to hospital for treatment before? And all of these are important because it will help us decide if patient need tonsillectomy in the future. So examination-wise, again, when you're looking inside patient's mouth, they can cough on you. So make sure you are fully protected as well. So this is a typical appearance of a bacterial tonsillitis. So you can see tonsils are enlarged, erythematous, and there's a lot of pus exudates on it. So other things to comment on when you're examining a patient with tonsillitis is to see the peritonsillar area, any bulge or any swelling around the tonsil. Look at the uvula. Is it deviated to one side or is it still in the middle? Look at the mouth opening of patient, whether there's trismus, and listen to the voice of patient, whether it's muffled or not. And if you're suspecting it might be infectious mononucleosis, which is a viral cause, you may want to check for any enlarged spleen or liver. In terms of investigation, you want to essentially check inflammatory markers to see whether there's raised white cell count. So usually if it's bacterial cause, you may have neutrophilia. If it's infectious mononucleosis, you may have lymphocytosis. And because patients have sore throat, so they will not be able to drink a lot of fluids, probably for the last 1 week. So you want to check the renal function to see if patient is dehydrated. And if you're suspecting, again, glandular fever, then you should check the liver function test and also monospot test. So the decisions of whether patient can be treated as outpatient or need to be admitted depends on the severity of the infection and also whether patient can take orally. So can they go home and take oral antibiotics and drink fluids at home? So if the odynophagia is so bad that the patient cannot take anything orally, then they should be admitted for IV treatment. So let's say for this case, the patient say they can still take orally, and therefore we can start patient on oral antibiotics. So usually it's a benzyl penicillin, or if they're allergic to penicillin, a clarithromycin. It's important to note that for antibiotics for tonsillitis, it's best to avoid amoxicillin or ampicillin because they are usually associated with causing rash in patients with glandular fever. And next, because patient came in with sore throat, with pain, so it's very important to start patient on analgesia. So regular paracetamol plus probably NSAIDs, ibuprofen or diclofenac, and the topical painkillers would help as well, like a deflam gargle or spray. And you need to encourage them to take orally because they're probably a bit dehydrated from reduced intake of fluid for the past week. So after that, you need to give a follow-up for maybe a week's time to once they finish their antibiotics with a safety net to ask patient to come back earlier or go to emergency department if there's no improvement or if there's any deterioration of symptoms. So let's say this patient came back to your practice 3 days later because he now claims that the odynophagia has worsened and now he feels systemically unwell with fever and unable to open the mouth fully, and therefore make it even more difficult to drink or eat and feels very dehydrated. So now you've decided to send the patient to emergency department to be seen by the ENT team in the hospital. So let's say you are now the ENT junior doctor on call who received the referral. So in terms of history, you already know the story. So patient had 1 week history of tonsillitis, had been started on oral antibiotics, and 3 days later, the condition has worsened with trismus. So on examination, this is a classic appearance of a left peritonsillar abscess or a left quinsy, which is a complication of inadequately treated tonsillitis. So you can see here. So this is the tonsil. It's been pushed medially and downwards, and there's a bulge in the peritonsillar area. The uvula is not in the middle. It's been pushed to the contralateral side. And the previous picture showed there's trismus as well, so limited mouth opening. So you should also examine patient for lymph node and for neck stiffness. And usually we will do a flexible nasendoscope to make sure there's no medialization of the pharyngeal wall, which is a complication of a deep neck space abscess, which can happen if the infection tracked down from here to the neck space, deep neck space. So this patient needs to be admitted to the hospital for fluid resuscitation, for IV antibiotics, IV analgesia, some blood tests. If patient is pyrexial, to do a blood culture as well. And most importantly, the treatment is to aspirate and to incise and drain the abscess under local anesthetic. So in order to drain the peritonsillar abscess, again, we need to prepare our instruments and make sure, first of all, that we are protected from the AGP. So this time, the aerosols or the droplets that they cough on you will be mixed with pus. So again, quite a lot of us have been sprayed with pus from peritonsillar abscess before on us. So make sure that you are fully protected. So in terms of other equipment, we need to be able to free both our hands. So we need a headlight to shine inside the mouth to see what we're doing. We need a tongue depressor so that we can see the tonsils clearly. Local anesthetic spray. And we need a needle with syringe to aspirate. And then we need a scalpel or a blade to make our incision, and an artery forceps to open up the incision. So in terms of location of where to drain, so the classic teaching in books is that you draw an imaginary horizontal line through the base of the uvula. So this is the uvula. So this is the base. So you draw a line here, and then you draw a vertical line along the anterior pillar of the tonsillar fossa. And then the line of intersection is where you should put your needle in to try and see if there's any pus that you can aspirate. And if there's nothing, generally we go down the vertical line to see if there's any anything here. And once you have managed to aspirate some some pus from your syringe, you can then make an incision along here, along the arch of the palate, normally about 1 cm, and open up the incision with artery forceps. Sometimes you can put a small suction in as well to take out the pus. And remember to take a sample of the pus for culture and sensitivity as well. So on the following day, during ward round, you need to look at that area to make sure that the swelling has reduced in size and that the opening is still intact and continue to drain pus. So if the opening is closed up, which happens quite often, you then need to reopen it with the artery forceps, because otherwise the pus will just reaccumulate inside the cavity and it will not improve. And patient will only be allowed home once the swelling has subsided, the trismus has resolved, and they are able to take orally again. And after that, we need to follow up patient and discuss about the need for tonsillectomy according to the guidelines. So this is the second case. So I'll move on to the last case, which is basically an ear case. So you're an FY1 in an ENT clinic, and the patient came in with a right-sided ear pain. So in terms of history, so you want to find out more about the otalgia itself, which is the presenting complaint. So same as any other symptoms, the onset, duration, exacerbating relieving factors, and any treatment that has been received so far. So most likely patient would say they have been started on some kind of antibiotics, which you don't want to repeat giving the same treatment again. And for ear, associated symptoms are any discharge, otorrhea, any hearing loss, any tinnitus, vertigo, and any itchiness. And then you want to find out about risk factor for what could have caused this to happen. So any regular usage of cotton bud, for example, and therefore they had left a bit of the cotton bud inside, which becomes infected. Whether they have been swimming in the lake or sea and therefore exposed to dirty water, whether they are prone to infection, for example, if they are immunocompromised or they are diabetic. So examination always starts from outside to in. So external ear, whether there's any cellulitis or skin changes in the pinna, where patient may need oral or IV antibiotics. And an otoscopy or otoendoscopy to look inside. So first of all, you want to look at the ear canal itself. Is it swollen? Is there any pus, any fungus spores, any polyps? And then you want to check whether the canal is patent or not, or is it very edematous that you can't actually insert your scope inside. And finally, at the end of the canal, you should be able to see the tympanic membrane. You want to comment on whether it is intact or perforated. So normally for an otitis externa, we don't usually do any culture sensitivity in the first contact with patient. We usually reserve them for infection that does not respond to treatment. But you can take some swab and send for culture if you want to. After that, you need to clean the ear. So you need to do ear toileting. So what you need is either a microscope or an autoendoscope to be able to look inside, and you need a suction to clean it. And first, we need to clean all the pus, or if there's any fungus spores, you can remove them. Or if there's any foreign bodies, you can also remove them with suction or with crocodile forceps. And then we will usually give topical ear drops. If it is fungal infection, we will give antifungal ear drops as well. And the important part is to give good instruction on how to apply these eardrops. So you need to tell them to lie on the opposite side. And when you put in the eardrops, after that, you need to rub the tragus so that, or massage the tragus so that the drops properly goes inside. And then to lie there for 5 to 10 minutes. Otherwise, if you go up, if you get up straight away, then the eardrops might just flow back up. And remember, patient coming with pain, so you need to give some analgesia. Post-treatment advice is very important as well. Make sure that they always have strict water precaution for their ears. So try to cover their ear when they are showering and avoid ear digging. So let's say this patient went home and then you get code from the same patient a few days later because the pain has increased and she feels that the ear is now becoming more blocked and the hearing has reduced. And when you examine the patient, so this is the ear canal. So it's completely blocked off and very edematous. You can't actually see inside and you can't see the tympanic membrane, which is quite common as well. So you know that if you send patient home like this with topical antibiotics, the drop is not going to get in. So you just accumulate outside and then it will flow back outside, flow back out of the ear. So no treatment can get through it. So what we need is a conduit to help us open up the ear canal and let the medications get in. So we need to give something like a pop wick, or if you don't have a pop wick, we can use ribbon gauze as well. So what it does is, so this is again similar to the marrow cells, a dehydrated sponge. So once we insert it into the ear canal, it will absorb all the pus and blood or fluid, and it will swell up. So, so this will have two functions. Number one, it will open up the ear canal because it's now swollen, and then it will also act as a stent or a conduit for your eardrop to go inside. So if you put eardrops here, it will get absorbed into the sponge and it will get distributed to the canal and to the tympanic membrane area. The thing about this is you need to come back to get it changed every 2 to 3 days. Otherwise, the sponge itself can act as a foreign body and can become infected. So a few days later, you need to come back, we'll change it and re-inspect, and hopefully we'll see improvement. So once the swelling has reduced and you're confident that patient's canal is now opened up and does not require this thing anymore, you can then send them home without this and just continue with the eardrops and antibiotics. All right, and again, so once they're home, the important part is water precautions. So this is quite a common thing that we can suggest patients to do. So basically, you can soak your cotton ball with Vaseline so that it's now a bit oily and waterproof. You can just put this outside the ear when you're showering to prevent water from going into the ear canal. Or you can buy something like this, which is basically a smaller version of a shower cap. So it's an ear cap that you can just put around the ear when you're showering to prevent water from going in. So I've finished presenting all the 3 cases. So can we move on to the Kahoot? And after that, I just have one more slide, just like to wrap up the session. Okay, so I'll just stop sharing and I'll share the Kahoot page. Okay. Okay, so let me know.
I think we've almost got everyone on.
Okay.
We've got a couple more people.
Should
Can
I?
everyone get on? Should we give it like 1 more minute and then?
Okay.
Okay, I think we should be able to start now.
Okay. All right. All right. Okay. I probably should have. Anyway, so I think most of you got it right. So it's basically lean forward, look down, and on the soft part of the nose. Okay. So next question. All right. So so the answer is actually posterior ethmoid. So the latest area is by anterior ethmoid, the sphenopalatine, greater palatine, and the superior labial artery. Okay. Next. Right. So most of you got it right as well. So so this is a Tilly's forceps. So this one is required for basically putting in, layering the anterior pack in. So this is the umbilical cord clamp to basically secure the catheter at the front of the nose, and this is the Foley's catheter. So this is a crocodile forceps, which is usually used for removal of foreign bodies or wax in the ear. Okay. Next. Okay, so because infective mononucleosis is actually a viral cause, so it's by Epstein-Barr virus. So the normal finding that you get is actually deranged liver function rather than renal function, positive monospot, and you get lymphocytosis instead of neutrophil increase. So this one is more of a bacterial cause. Okay. Next. Okay, so most of you got it right. So to drain a tonsil, peritonsillar abscess, you need a headlight to look inside. You need to depress the tongue, a tongue depressor to see the tonsil. You need a knife or blade to cut open the area so that it can drain. So this is a forceps. So normally we use an artery forceps rather than tooth forceps like this. Okay. Okay, well done, Ryan. Okay, so I didn't really go through the guideline earlier in my talk. So, but this is a well-known guideline that's practiced in UK. So it's the SIGN guideline, Scottish Intercollegiate Guidance Network guideline, for when do we think we should recommend patients to have a tonsillectomy for recurrent tonsillitis. So basically, who can benefit from having a tonsillectomy done? So usually it's 7 times a year or 5 times over 2 years period, so instead of 3, and 3 tonsillitis over the last 3 years per year. So 3 tonsillitis per year for 3 years consecutively, or usually 2 peritonsillar abscess in total. So if you've already had 2 quinzies, then you should get your tonsils removed. Okay. Okay, so that's correct. So what can cause otitis externa? So one of the commonest causes is basically people keep digging their ears, trying to remove wax, or because it's itchy. So, or they think after shower they need to somehow dry it with cotton bud, and accidentally left a bit of the cotton bud tip inside, which becomes infected. Okay, so using earplugs in swimming pool is usually what we can recommend to reduce the risk of infection because you are protecting the water from going in. So loud music generally doesn't cause otitis externa. It can cause noise-induced hearing loss. And flying an airplane doesn't cause infection. Okay. All right. Yeah, it might be because it's a bit difficult to see on your screen, but basically this just shows that there is a lot of pus in the ear canal, so it can be because of infection. And this one is actually from, basically I'm trying to show a perforated eardrum. But there's no signs of infection because there's no pus, there's no edema, but there's a hole here. This is actually tympanosclerosis. So this could be from constant ear digging or previous trauma, and it's now healed, and therefore it's now sclerosed. So this white patch is the sclerosis. And this picture is actually showing bubbles and fluid behind the eardrum, and which is basically signs for otitis media with effusion. Okay, last one. So most of you got it as well. So not required for ear toileting. So this is the Tadicum speculum, or Tadicum is for the nose to basically increase the size of the nostril for you to have a look inside. So this is a suction for ear toileting. This is a microscope, and this is the ear speculum to open up the ear canal so that you can see better. Okay. All right, so congratulations to everyone. I hope that was useful. So I'll just show you the last 2 slides. Okay. Right. Okay, so just some take-home message. So number 1, always remember to protect yourself, especially when you're doing ENT examinations, because we are known to basically, most of our examinations are known to be aerosol generating procedures, especially during this COVID time as well. And number 2, always assess whether patient needs to be resuscitated first, because a lot of ENT emergencies will involve airway. So if it is an airway, then you need to resuscitate patient. Or if it is a torrential bleed from the nose, you need to resuscitate first before doing anything else. Number 3, always be familiar with the equipment that we use, because they are quite specific and has specific function. Number 4, don't forget to treat any underlying cause for the conditions that you see. So this is for across all other specialty as well. Don't just treat the presenting complaint. You need to treat what has actually caused this to happen. Otherwise, the patient will come back with the same problem again. And finally, always make sure that you give good instructions, and therefore good communication skills is quite important. For example, we always need to make sure we tell patient or teach patient how to put eardrops properly, how to use the correct way to use nasal spray, post-tonsillectomy advice, for example. So all of these will ensure compliance and effectiveness of treatment and prevent patient from coming back with a recurrent problem. So here are my contacts. If you have any questions about ENT or career pathway, doing elective here, or just coming here for holiday after the pandemic, feel free to ask me anything or contact me. So thanks again.
That was brilliant. Thank you so much, Dr. Eugene. So we're now going to do a Q&A session. So we've got a question coming. So feel free to send in your questions and I'll start reading them out. So the first one we have is it possible for recurrent use of earplugs when swimming to cause an increase in the humidity of the ear and cause otitis externa?
Okay, I guess so I think what you're asking is to reuse the same earplugs, or is it? So I guess if your earplugs is clean, because you are not in the water for that long an amount of time, I think, and therefore it shouldn't be a cause for otitis externa, because normally you need to have in contact with polluted water. So for example, in the sea or in the river, where the water might be infected and goes into your ear. So if you are swimming with an earplug, it should protect your ear from getting in contact with those pathogens. But unless the earplug itself is dirty because you've not been cleaning it, then I guess then that could cause infection.
Okay, good. I don't think we have any more questions. Actually, no, we have another one. So what would you say is the most common ENT issue that you see in the clinic?
Okay, so those three are definitely very common. So infection of the ear, foreign bodies in the ear, especially in children. So because they like to put things inside so beads and different things. Earwax, impacted earwax, mainly because people like to clean their ear, but at the same time, they're actually pushing all the ear and compacting it inside the canal, and therefore they come in with hearing loss because they can't hear because it's full of wax. Other things for the nose, very common is allergic rhinitis. So I think in UK it's mainly seasonal because you have pollens and grass during spring and summer. For over here, it's mainly all the time because in some places the air is quite polluted, so maybe dusty, so they are allergic to those things. So they come in with a lot of sneezing and rhinorrhea, runny nose all the time. For the throat, so yeah, so infection, so sore throat, any voice change, loss of voice, for example. So yeah, so these are the common things that we see.
Brilliant, thank you. So I don't think we have any more questions.
Yeah, no problem.
If anyone has any burning questions, can you send them in now? Otherwise, I think we're almost done. So thank you so much again, Dr. Eugene, for speaking to us. We've had a lot of fun with the past two webinars, and I think personally they've been really, really useful for us as revision, but also for people who are going to be doing ENT soon. I've actually got two feedback forms. One was from your previous webinar, so if everyone could fill that one in. I'm just going to attach them here in the chat, so hopefully they're coming in now. So if you could fill them in, give us any feedback, and if you want to give Dr. Eugene feedback, please include that and we will send it over to him. So thank you again, Dr. Eugene. And thank you to everyone else who has joined us. Hopefully this has been useful, and we hope to see you again in December for our talk on oncoplastic surgery. Brilliant.
Okay, thank you.
Thank you, Dr.